kidney disease, the impact of kidney disease on women health, which is first of all, I would like to say that with change in globalization and change in our lifestyles, this is becoming more and more important, specifically both for male and female. But here we'll mainly focus on women's health. So, what are the numbers? The kidney disease affects 14% of women in the United States compared to 12% of men, making it a leading cause of premature mortality in women. Despite the significant impact, awareness about the unique sex-specific consideration and risks remain limited in both clinical practice and public health discourse. This condition disproportionately impacts women's life expectancy and quality of life, and how it happens we'll learn in the next slides. As the kidney disease rates continue to rise globally, understanding these sex-based differences becomes increasingly critical for effective prevention, early detection, and treatment strategies. This presentation will explore the unique challenges that the woman will face with kidney disease and also how to approach this case. Next. Yes. So again, numbers are important for analyzing anything. So 14% of women with CKD, as I mentioned, in comparison to 12% of the men, this is the US data. If you look at the global data, it is 16.8 versus 9.1% in terms of men. If you look at years of life loss, it's 3.6 additional years life loss compared to men, and 11 times more mortality increase in comparison to men, where it is 7 times more mortality increase when you have a kidney disease. Next. So, if you look at kidney disease from women's point of view, women experience chronic kidney disease at higher rates. With this disparity, this gender disparity present both in developing as well as developed countries. In terms of demography value, that the African American women, they face particularly elevated risk with rates significantly higher than other demographic groups. The type 2 diabetes serves as primary driver of kidney failure in women, creating overlapping health challenges. Age-related trends, they show the concerning increase in kidney disease is evident among women over 50, coinciding with the hormonal changes of menopause. Next. So one of the first challenge that happens in case of kidney health is the asymptomatic nature of the early kidney disease. The kidney function can decline significantly before any symptoms appear. This is true for both male and female. Underdiagnosis. Specifically, this applies to countries like India, where proper diagnostic facilities are not available, and also public awareness is not there for silent killer like diseases like kidney disease. Sex-specific gaps are definitely there. The availability or access to healthcare is different for male and female. Males are more important when it comes to seeking medical care, and there are specific data in India which attribute to this fact. Screening deficiency, insufficient targeted screening for high-risk female population. Next. Next. So as you can see, this is a graph which shows that the difference in between male and female, and you can see that after the age of 40 to 49, that is when the females they hit the menopause, then the problem starts, and there is a sex separation which is clearly visible, with women being more prone to the mortality and morbidity effect of kidney health. Next. So hormonal influences, what are the hormonal influences on kidney function? Estrogen offers protective effects on the kidney through vasodilation, reduced fibrosis, and anti-inflammatory properties. Progesterone, on the other hand, leads to sodium retention and blood pressure regulation, impacting kidney function. Once menopause happens, the declining estrogen levels accelerate kidney function decline post-menopause, and pregnancy, which is a very important event in any female's life, has dramatic hormonal shifts which can cause temporary kidney adaptations and potential complications. Next. So what are the key risk factors for women? It is almost same as male with a few differences. Type 2 diabetes, hypertension, obesity, metabolic syndrome is common for all, but autoimmune conditions and pregnancy complications are unique for female population. Next. There are also some racial and ethnic disparities. We know that African American race, both women and female, have increased risk of kidney failures compared to Caucasian population. And this is one of the significant disparities in kidney health outcome. Similarly, if you look at diabetes as a primary driver, diabetes, the prevalence is also higher when it comes to African American race. And if you look at the social determinants, there is limited healthcare access, economic barriers, and food insecurity and environmental factors disproportionately affect women of color, creating barriers to prevention, early detection, and optimal management of kidney disease. Next. Mortality impact, if you look, early CKD women show 1.2 to 1.5 times higher mortality risk than age-matched women without kidney disease. In case of moderate CKD, this increases to 2 to 3 times. Dialysis initiation, women experience 8 to 10 times higher mortality risk. And in advanced kidney failure, this I already mentioned, that is 11 times more risk in comparison to only 7 times in men. Next. So what is the impact on the quality of life? Symptom burden: women report higher levels of fatigue, sleep disturbance, and pain associated with kidney disease. These symptoms often interfere significantly with their daily activities and functionality. What is the psychological impact? Depression and anxiety rates are 30 to 40% higher in women with kidney disease in comparison to men. What about body image concerns? The changes that happen with kidney health affects the woman much more in a greater form than in men. For example, fluid retention, skin changes, and dialysis access sites. Social load disruption: women with kidney disease often face, previous slide please. Women with kidney disease often face significant challenges maintaining caregiving roles and family responsibilities, creating additional psychosocial stress. Next. So as you can see that the economic burden for direct medical is the highest. Also, there are burdens like medication, transportation, lost wages, caregiver costs, and child care, which is specific because the role for a female is much bigger than for a male. Next. When it comes to cardiovascular complications, the cardiovascular risk is elevated 20 to 30 times higher for a woman with kidney disease. Women have another peculiarity. They often have atypical symptom presentation. We already know they suffer from things like angina equivalents, atypical anginas, where they often present with fatigue, shortness of breath, and back pain rather than the classical symptoms. There is definite treatment disparities again when it comes to cardiovascular interventions and preventive. There is definite sex separation, and there is some problem in monitoring challenges. For example, standard cardiovascular risk calculators often underestimate the risk in women with kidney disease. Next. Another important point is the bone health. We all already know that after the menopause, there is some bone health in the form of bone health deterioration in the form of osteoporosis, which affects women much more than men. So dual risk factors is there. It can be considered as a perfect storm where kidney disease related bone mineral disorder as well as estrogen related bone loss both happen together. The diagnostic challenge is standard bone density testing may not be accurately reflective of the fracture risk that might happen in the background of kidney disease. Functional impact is fractures in women with kidney disease leads to a greater functional decline, higher rate of nursing home placement, and increased mortality compared to the general population. Next. Now we can focus on the reproductive health, which is another important concern when it comes to female with chronic kidney disease. There are definite menstrual changes which starts as early as the early stages of chronic kidney disease. As the kidney function declines, women experience progressive changes in menstrual pattern. Irregular periods often begin as early as the kidney function drops to around 50%. Amenorrhea, and it further complicates with advanced kidney disease. Fertility changes, definitely there is fertility loss and the childbearing capabilities go down. Higher level of waste products in the bloodstream interfere with egg production, the hormonal regulation, and also the health of the fetus. Sexual health impact: women with kidney disease report higher rates of sexual dysfunction, including reduced desire, difficulty with arousal, and discomfort during intercourse. Next. So you can look that if you look at the typical menstrual changes that can start as early as stage 2 CKD, when prevalent are the normal patterns, but when it enters stage 3, that is less than 60%, the 60 EGFR, then the irregular cycles begin. They gradually increase in irregularity as we progress to stage 4 and stage 5. Ultimately, stage 5 and or dialysis have a significant percentage of 75 to 80% of women having amenorrhea. Similarly, the clinical implication is that this will affect the fertility. This will naturally, the question of contraception will come in, and there is also some considered EPO impact on menstruation return. Next. So pregnancy with pre-existing kidney disease carries significant risk for both mother and baby. Women face 3 to 4 times higher rates of preeclampsia, gestational hypertension, and preterm delivery compared to women without any kidney disease. The severity of this risk correlates directly with the degree of kidney dysfunction and the presence of proteinuria before conception. Successful pregnancy outcomes require specialized preconception counseling and multidisciplinary care throughout pregnancy. The healthcare team typically includes nephrologists, maternal fetal medicine specialists, specialized nurse, and nutritionists. And what we do from nephrology point of view is that whenever a patient with a pre-existing kidney disease becomes pregnant and comes to us, or comes to us for a whether to become pregnant, but for our advice, then we see what grade she is lying, what is the stage of the CKD, and accordingly we counsel both for the mother's health and the fetal health, and then we give a open basket choice and we proceed. Next. So if you look at the pregnancy outcome, definitely there is higher risk of preeclampsia, higher risk of preterm delivery, higher risk of low birth weight, and this increases as the kidney function decline, and mother's kidney function decline. All the kidney function can also decline as she passes through the various stages of pregnancy. Next. So the effect of menopause and kidney function is a bit different, and that also we have to consider in women's health. As the estrogen decline, loss of kidney protective hormonal effects goes away. There is accelerated kidney aging, faster GFR decline in postmenopause compared to men. Bone kidney axis disruption, I already said, is a dual thing combined with osteoporosis, the kidney related CKD-MBD, that is mineral bone disorder, and increased risk of cardiovascular events, which is synergistic with declining kidney function. Next. Psychosocial impacts, I have already said. Body image concern, it is specific for women. Men are not so much bothered about that. Relationships trend because women has a particular role in our society, and caregiving role because of their child care, because of their role in the family. So all of these are disrupted if a female has acquired any kidney disease. Next. So what are the preventive strategies for this unfortunate patients, for this woman who acquire any kidney disease? We have to ensure a risk-based screening in the form of implement regular kidney function screening for women with diabetes, hypertension, autoimmune conditions, those who have had a history of preeclampsia. Those patients who have PT or preeclampsia, they often end up developing some degree of renal dysfunction or hypertension in their later life. Similarly, family history of kidney disease previously. Dietary approaches, the same DASH diet which is applied for management of hypertension is also applied in this case. This diet emphasizes on fruits, vegetables, whole grains, lean protein, and limited sodium, less than 5 gram consumption per day. Regular physical activity of at least 150 minutes per week. These are given by all big guidelines. Medication awareness, review all medications, prescriptions over the counter, and specifically be careful about rampant use of NSAIDs, which can cause kidney function decline. Next. So, what is the early detection recommendation? These are by the big guidelines, be it KDIGO, be it EDA. So, women with diabetes, you have to monitor the EGFR and urine ACR annually, and nephrology referral accordingly. History of preeclampsia, you have to measure the blood pressure, EGFR, and urine protein every 1 to 3 years. This is what I emphasize, that many patients of preeclampsia often end up with hypertension. Autoimmune disease, you have to select accordingly, test for EGFR, urine protein, and blood pressure every 6 to 12 months. Family history of kidney disease should undergo EGFR urine analysis every annually or biannually. Postmenopausal with hypertension, EGFR urine protein, and cardiovascular risk assessment annually. Next.
There are 2 minutes left.
Yes. Next. Yeah. So, sex-specific treatment consideration, medication dosing, women's different body composition affects medication distribution in a different way, the metabolism and the clearance. This physiological difference should be kept in mind when we are prescribing medicines. Hormonal consideration should be kept. For example, estrogen may offer several kidney protective role. It also carries potential CV and thrombotic risk, we already know. Nutritional needs, women with kidney disease have specific nutritional requirement that different from men due to hormonal influence. Bone health consideration, iron need, we know this suffer more from anemia because of the ongoing menstruation, and also they have higher degrees of bone mineral disorder defects. So iron supplementation protocol should account for the menstrual blood loss, and along with calcium, vitamin D recommendations as per the guidelines should be considered. Next. In case of dialysis, just 2 slides I will share for dialysis and transplant. For dialysis, vascular access is a problem because females tend to have the vessels of females tend to are not so amenable for creating vascular access, and also higher primary failure rates. Psychosocial support, again, it emphasizes on body image concern, caregiver role, and higher reported depression rate, which I mentioned. Nutritional needs are much more challenging for females. Anemia management is even challenging because of the ongoing menstrual blood loss. The erythropoietin response is often subliminal and higher transfusion requirements, which is observed in females with on dialysis. Next. Similarly, for transplant, if you look at donation patterns, women are more likely to donate kidneys than receive. Fertility after transplant, kidney transplantation often restore fertility with menstrual function, typically returning within 6 months. And immunosuppression effects, women experience higher rates of certain immunosuppression side effects, including hirsutism, gingival hyperplasia, and osteoporosis. These effects can have significant impact. Support system for women, peer support network should be created, reproductive health services should be there in both developing and developed countries. Financial navigation, that is very important because women and men, there are some gender disparity when it comes to financial allotment and psychological services for their various depression, anxiety, and other adjustment difficulties. Next. These are some research
Sir,
priorities
time is
that you
up.
can consider. Yes, we are almost done, sir. Sex-specific mechanisms, treatment response difference, hormonal transition, pregnancy and kidney health, and diverse population studies which need further research, we can give us some new avenues. Next. So advocacy at next. Next. Yeah. So patient empowerment strategy, knowledge building, self-advocacy skills, shared decision making, and community engagement are all important parts of tackling kidney health in women. Next. So this is the sum up. So you have to create an integrated care model where nephrology, women's health, and primary care coordination should be there. Sex-specific awareness should be there. Recognition of unique risk factors and disease presentation. Targeted prevention, life stage appropriate strategies for women. Expanded research, as I have mentioned, and policy support. The country has to take specific policies for to support women with kidney diseases. Next. Thank you.